Every 65 seconds, someone in the United States is diagnosed with Alzheimer's disease or another form of dementia. By the time you finish watching this video, dozens more families will have sat in a doctor's office and heard words that changed everything. And for a number of those families, the diagnosis did not have to happen, or at least did not have to happen this soon, because what looked like dementia was being quietly driven by something sitting in their medicine cabinet. I am Dr. Adam. I have spent years working in the field of geriatric health, and one pattern I keep returning to is this. We accept cognitive decline in older adults far too readily. We tell people it is age. We tell them it is hereditary. And we almost never stop to ask whether something they are swallowing every single day might be eroding the very architecture of their memory. Today, I am going to walk you through 9 categories of medication that current research links to cognitive decline, memory loss, and an elevated risk of dementia. I will count them down from the ones most commonly overlooked to the one I consider most urgently misunderstood. I will tell you what the science actually says, what safer alternatives may exist, and what questions you should be bringing to your doctor. One important note before we begin. Nothing in this video is medical advice, and you should never stop or change a prescription without speaking to your physician first. Some of these medications are also protecting your heart, your lungs, or your mental health, and stopping them suddenly can cause serious harm. The goal is information, so you can have a more complete conversation with the person managing your care. Let's start at number 9. Number 9. Over-the-counter, sleep aids and antihistamines. Diphenhydramine sold as Benadryl, Unisom sleep tabs, Tylenol PM, and others. The most dangerous assumption in medicine is that something sold without a prescription must be gentle. For older adults, that assumption can be genuinely harmful. Diphenhydramine is found in the vast majority of over-the-counter sleep aids and many allergy and cold products. It is inexpensive, widely available, and used by millions of people every night. And it belongs to a class of drugs that researchers have spent the last decade connecting to accelerated cognitive decline. The class is called anticholinergics. These medications block a brain chemical called acetylcholine, which your neurons rely on to communicate with one another and to form new memories. Your brain naturally produces less acetylcholine as you age, which means anything blocking what remains hits an older brain significantly harder than it would a younger one. The region most directly affected is the hippocampus, the brain structure responsible for encoding new memories before they can be stored elsewhere. When acetylcholine signaling is repeatedly disrupted in this region, the effects compound over time. A large study led by researchers at the University of Washington followed more than 3,400 adults aged 65 and older over a 10-year period and found that cumulative use of strong anticholinergic medications, including antihistamines like diphenhydramine, was associated with a significantly elevated risk of developing dementia. Those with the highest cumulative exposure had a 54% greater risk than those who avoided these drugs entirely. A broader analysis of more than 284,000 adults aged 55 and older found that anticholinergic use was associated with a 49% increased risk of dementia. With a dose-dependent relationship, the more someone took and the longer they took it, the steeper the risk. What makes diphenhydramine particularly insidious is how hidden it is. It appears under dozens of brand names. When someone reaches for a PM version of a pain reliever or a nighttime cold formula, they may not realize they are adding an anticholinergic drug to their daily routine. What makes diphenhydramine particularly to do? Read ingredient labels on anything marketed for sleep, allergy, or nighttime symptom relief. If diphenhydramine is listed, that is the conversation to have with your doctor. For allergies, second-generation antihistamines such as loratadine, Claritin, or cetirizine, Zyrtec, do not cross the blood-brain barrier as readily and are generally considered safer for long-term use. For sleep, behavioral approaches and melatonin are worth exploring first. Never stop any medication without medical guidance, but do start asking questions. Number 8. Proton pump inhibitors. Sold as omeprazole, Nexium, pantoprazole, and others. Proton pump inhibitors, PPIs, are among the most prescribed medications in the world. They suppress acid production in the stomach and are used for heartburn, acid reflux, and peptic ulcers. Many people use them daily for years, often without revisiting whether they still need them at the same dose. Here is what rarely comes up at the pharmacy counter. Your stomach acid is not just a source of discomfort. It is essential for absorbing certain nutrients, and the one most critical to brain function is vitamin B12. Vitamin B12 is required for maintaining the myelin sheath, the protective covering around nerve fibers that allows electrical signals to travel efficiently through the brain and nervous system. When B12 levels fall too low, the result can include memory difficulties, confusion, and cognitive changes that closely resemble early dementia. PPIs, by chronically reducing stomach acid, impair the body's ability to extract B12 from food. Magnesium, another mineral with important roles in neural signaling, is similarly affected. Beyond the nutrient pathway, some researchers have identified a more direct concern. Laboratory studies have shown that PPIs may increase beta amyloid production in brain cells, beta amyloid being the protein that accumulates in the plaques found in Alzheimer's disease. Whether this translates meaningfully to clinical outcomes in humans is still being actively studied, but it is a mechanism researchers take seriously. A large analysis of more than 73,000 adults aged 75 and older found that regular PPI users had a 44% higher risk of dementia compared with those not taking these medications. And research has consistently shown that long-term PPI use is significantly associated with vitamin B12 deficiency, providing a clear biological pathway through which these drugs may affect the brain. The difficulty with PPIs is that stopping them suddenly can cause a rebound effect, where acid production temporarily overshoots and symptoms feel worse than they did before the medication began. This often convinces people the drug is indispensable when it may not be. What to do? If you take a PPI every single day, ask your doctor whether you still need it at that dose or whether a step down to an H2 blocker, such as famotidine, Pepcid, might be appropriate. H2 blockers reduce acid through a different mechanism and have a much smaller observed association with cognitive effects. If you remain on a PPI long-term, ask your doctor about monitoring your B12 and magnesium levels. Number 7. Bladder medications sold as Ditropan, Detrol, Vesicare, and others. Overactive bladder is a condition that genuinely disrupts lives. The urgent, unpredictable need to find a bathroom can lead people to stop going out, withdraw from activities they once loved, and feel confined by their own body. The medications prescribed for it provide real relief, and the desire to take them is entirely understandable. But the most commonly prescribed bladder medications, oxybutynin in particular, work by blocking the muscular contractions of the bladder wall through the same mechanism that appears throughout this list. They block acetylcholine receptors. And unlike some anticholinergic drugs that stay mostly in the body, oxybutynin crosses the blood-brain barrier readily, acting directly on the same memory-forming systems we discussed at number 9. The research on this class is among the most consistent in the field. Studies examining large populations of adults over 65 have found that people who took strong anticholinergic drugs, with bladder medications forming a major share of the exposure, for more than a year had a significantly elevated risk of developing dementia, with the risk climbing the longer these medications were used. One study examining more than 170,000 patients with newly diagnosed dementia found that those who had taken anticholinergic bladder drugs had a notably higher dementia risk than matched controls, with oxybutynin showing the strongest association within this drug class. A nationwide Swedish analysis, including nearly 200,000 individuals with incident dementia, identified urinary antispasmodics as among the drug classes showing the clearest dose-response relationship with dementia risk, meaning the more someone took, the more their risk increased. Importantly, there are alternatives. Mirabegron, works through a completely different mechanism, relaxing the bladder muscle through beta-3 adrenergic receptors rather than blocking acetylcholine, and does not carry the same cognitive risk profile. For many patients, it provides comparable symptom relief without the brain burden. What to do? If you take a bladder medication and have noticed changes in memory or thinking, discuss it with your doctor. The switch to mirabegron may be worth exploring. Pelvic floor physical therapy has also shown meaningful benefit for overactive bladder with no medication involved at all. Number 6. Prescription. Sleep medications. Sedative hypnotics. Sold as Zolpidem, Ambien, Lunesta, Sonata. These are the medications most commonly prescribed when someone tells their doctor they cannot sleep. Known as Z drugs, they work by enhancing the activity of GABA, the brain's primary inhibitory chemical, which reduces neural activity across large regions of the brain and produces the sedation that allows sleep to come. The short-term benefit is real. For acute insomnia triggered by stress or life disruption, they can provide meaningful relief. The problem emerges with prolonged use, which is exactly how many people end up taking them, because insomnia tends to be chronic, and once a medication produces reliable sleep, stopping it becomes very difficult. Research following elderly adults over multiple years has found that Zolpidem use was associated with a significantly elevated risk of developing Alzheimer's disease, with the risk increasing with cumulative dose. Other studies have found that older adults who use these medications regularly had an increased risk of a reversible dementia syndrome, and that this risk grew with the duration of use. Beyond the direct dementia association, these medications suppress the deep, slow-wave sleep and REM sleep that are essential for memory consolidation and for the brain's overnight cleaning process, during which cerebrospinal fluid flushes out metabolic waste products including beta amyloid. So they may simultaneously impair the brain's natural defense mechanisms while also directly interfering with how memories are formed and stored. What to do? Cognitive behavioral therapy for insomnia, known as CBT-II, has consistently outperformed sleep medications in clinical trials for chronic insomnia, with effects that persist long after treatment ends. If you take a prescription sleep medication regularly, ask your doctor about a supervised taper and a referral to a behavioral sleep specialist. Melatonin, used at low doses at the right time relative to your sleep schedule, can also serve as a gentler bridging option. Number 5. Benzodiazepines. Sold as Cerazepam, Diazepam, Xanax, and Klonopin. We move now from sedative hypnotics to a closely related class, benzodiazepines, which act through the same GABA pathway and are prescribed for anxiety, panic disorder, muscle spasm, seizure prevention, and sleep. For millions of older adults, these have become a daily prescription that began years or even decades ago. The research linking benzodiazepines to dementia risk is extensive and has been building for more than a decade. A widely cited study drawing on data from nearly 9,000 participants found that people who used benzodiazepines for 3 months or more had a risk of Alzheimer's disease that was between 43 and 51% higher than non-users. The longer acting the drug and the longer it was taken, the stronger the association. A later meta-analysis, pooling results across multiple observational studies and countries, confirmed that long-term benzodiazepine use was associated with a significantly elevated risk of dementia, with consistent findings across different study designs and populations. Beyond sedation, chronic benzodiazepine use has been shown to reduce the brain's capacity for neuroplasticity, the ability to form and reorganize neural connections, and to impair the consolidation of memory during sleep. In some individuals, long-term use is also associated with structural changes in the brain, including reductions in hippocampal volume. A critical safety point that must be stated clearly: benzodiazepines can cause dangerous withdrawal, including seizures, if stopped abruptly. This is not a medication you can simply decide to stop. A slow, supervised taper, sometimes taking months, is required. What to do? If you take a benzodiazepine daily and have been doing so for more than a few weeks, raise this with your prescribing physician. There are non-benzodiazepine approaches to anxiety, including buspirone, certain antidepressants, and structured psychotherapy that do not carry the same cognitive burden. The taper must be gradual and medically supervised. Do not attempt to stop on your own. Number 4. Statins. a nuanced picture. Commonly sold as simvastatin, Lipitor, and Mevacor. I want to approach this one carefully because statins save lives. They reduce cardiovascular events, prevent strokes, and are a cornerstone of managing cholesterol in people at elevated risk for heart disease. This section is not an argument against statins. It is an argument for precision in how they are used. The brain is approximately 60% fat by dry weight, and cholesterol is an essential structural component of neural cell membranes and the myelin sheath that insulates nerve fibers. The brain actually manufactures its own cholesterol, independent of the bloodstream. When certain cholesterol-lowering medications cross the blood-brain barrier, as some statins do more readily than others, they may interfere with this local supply. Research has found that older adults on statins for more than 3 years showed higher rates of mild cognitive impairment, with the association being stronger for lipophilic statins, those that dissolve in fat and cross more easily into brain tissue. Simvastatin and atorvastatin fall into this category. The FDA acknowledged reports of cognitive side effects from statins and added information about memory loss and confusion to the safety labels of all statin medications in 2012. The contrast matters. Pravastatin and rosuvastatin are hydrophilic statins. They dissolve in water rather than fat and penetrate the brain less readily. These are generally considered to carry a lower cognitive risk profile, and some evidence even points to modest neuroprotective effects through their anti-inflammatory and cardiovascular protective properties. What to do? If you are on a statin and have noticed memory fog, confusion, or word-finding difficulty that emerged or worsened after starting the medication, bring this up with your doctor. The question is not whether to protect your heart, it is whether your current statin, at your current dose, is the right tool. Switching to a hydrophilic statin may preserve cardiovascular benefit while reducing the cognitive burden. Never stop a statin on your own. Number 3. Tricyclic antidepressants, sold as amitriptyline, nortriptyline, imipramine. Tricyclic antidepressants are an older class of medications developed for depression, but now prescribed far more often for nerve pain, migraine prevention, and sleep. Because they are being used for these secondary purposes, many people taking them do not even realize they are on an antidepressant. They were simply told it would help with pain or help them sleep, and they have been taking it ever since. What makes this class particularly significant on this list is that tricyclics are among the most potent anticholinergic medications still in common use today. Amitriptyline scores at the highest level on the anticholinergic cognitive burden scale, a standardized tool researchers use to quantify how heavily each drug loads the brain's cholinergic system. A large 10-year study following more than 3,400 adults aged 65 and older found that those with the highest cumulative anticholinergic exposure, to which tricyclic antidepressants contributed substantially, had a 54% higher risk of developing dementia. Critically, this risk did not require high doses. Small nightly doses, taken over years, were enough to accumulate meaningful burden. The American Geriatric Society, 2023. Beer's Criteria, an authoritative and regularly updated list of medications considered potentially inappropriate for older adults, explicitly identifies tricyclic antidepressants as medications to avoid in people over 65, due to their anticholinergic properties, sedation risk, and established association with cognitive impairment. For nerve pain, alternatives such as duloxetine, Cymbalta, or gabapentin, Neurontin, work through different mechanisms and carry a far lower anticholinergic burden. For depression and anxiety in older adults, SSRIs are generally better tolerated and safer from a cognitive standpoint. What to do? If you take amitriptyline or another tricyclic, particularly for sleep or pain, rather than a formal depression diagnosis, ask your doctor whether an alternative could work equally well. This is especially important if you have noticed any decline in memory, word finding, or mental clarity since starting the medication. Before we reach number 2 and number 1, has anything on this list surprised you? Leave a comment below with how many prescriptions you currently take and whether any of these medications are among them. I read these comments and they shape what I cover in future videos. If this has been useful so far, tap the like button. it helps this information reach the people who need it most. Number 2. Antipsychotic medications used off-label, sold as quetiapine, Risperdal, olanzapine, haloperidol. Antipsychotic medications were developed for serious psychiatric conditions, schizophrenia, schizoaffective disorder, and bipolar disorder with psychotic features. They work primarily by blocking dopamine receptors, and in the right clinical context, they can be genuinely life-changing. The concern is not with their intended use. The concern is with how frequently they are now prescribed off-label to older adults for insomnia, agitation, anxiety, or behavioral symptoms in people with dementia, often without a full discussion of the cognitive risks involved. Dopamine is not only involved in mood and reward. It plays a central role in attention, working memory executive function, and the motivation to engage with the world. When dopamine signaling is broadly suppressed, the cognitive and behavioral consequences can be severe, particularly in brains that are already vulnerable. Research examining more than 25,000 older adults found that those given antipsychotic medications had significantly accelerated cognitive decline within 1 year of starting treatment, even among individuals with no prior history of dementia. The FDA has issued a black box warning, its strongest safety alert, indicating that antipsychotic medications are associated with an increased risk of death in elderly patients with dementia-related psychosis, as well as an increased risk of stroke. Despite this warning, off-label prescribing in older adults remains common, particularly in nursing homes and assisted living facilities. Families often describe watching a relative, someone who was confused or restless, become quiet and still after starting one of these medications. The behavior that was difficult to manage disappears, but so often does the person. The emotional flatness, the withdrawal from conversation and relationships, the absence of the personality that was once there, these are not neutral side effects. They represent a significant reduction in quality of life and, in many cases, an acceleration of the very decline families were hoping to slow. Non-pharmacological approaches to agitation and behavioral symptoms, including structured routines, reduced environmental stimulation, adequate treatment of underlying pain or discomfort, and improved sleep hygiene have strong evidence behind them and should almost always be tried first. What to do? If you or a loved one is taking an antipsychotic medication and it was not prescribed for a diagnosed psychotic disorder, ask the prescribing physician to explain the clinical rationale and to confirm whether it remains necessary. Ask specifically about the FDA black box warning and what the plan is for eventual discontinuation. These are appropriate, reasonable questions, and any physician should be willing to answer them. Number 1. The combination: polypharmacy and total anticholinergic burden. You may have been expecting a single worse drug. The reality is more complex and in some ways more actionable. The greatest medication-related risk to brain health in older adults is not any single pill. It is the uncalculated accumulation of multiple medications, each with some degree of anticholinergic effect, taken simultaneously with no one tracking what they add up to. This is what researchers call anticholinergic burden, and it is where the science is most consistent and most alarming. Consider a scenario that is genuinely common. An older adult takes diphenhydramine at night for sleep, oxybutynin during the day for bladder control, and amitriptyline in the evening for nerve pain. Each one individually might appear to be a modest exposure, but each is blocking acetylcholine from a different direction at the same time, and their effects do not simply coexist. They compound into a cumulative load the brain is quietly struggling to absorb. A prospective cohort study following healthy older adults in Australia and the United States found that a high anticholinergic burden at baseline was associated with a 36 to 58% higher risk of developing incident dementia and ischemic stroke over nearly 5 years of follow-up. A comprehensive systematic review synthesizing data from nearly 150,000 patients across multiple countries confirmed that anticholinergic use for 3 months or more was associated with an average 46% increase in dementia risk, with a clear dose-response relationship. Each additional anticholinergic drug adding to the cumulative burden. Perhaps most sobering, A large analysis of adults in England estimated that anticholinergic drug use may account for approximately 10% of dementia diagnoses in older adults. That is 1 in 10 cases of dementia potentially linked to medications that are not always necessary and not always monitored for their combined effect on the brain. Most older adults taking multiple medications have never had a comprehensive review focused specifically on anticholinergic burden. No one has sat with them and added up the score. No one has looked at the full picture. That is where enormous preventable harm accumulates quietly and invisibly, year after year. The tools to change this exist. The Anticholinergic Cognitive Burden Scale and the Drug Burden Index are standardized instruments that assign scores to individual medications and sum them. A pharmacist or geriatrician familiar with these tools can perform a full medication review, identify which drugs are contributing most to the cognitive load, and determine whether safer alternatives are available. What to do? Ask your primary care physician for a comprehensive medication review with specific attention to anticholinergic burden. If possible, ask for a referral to a geriatric pharmacist or a geriatrician who specializes in medication management for older adults. Bring every medication you take, every prescription, every over-the-counter supplement, every sleep aid and allergy pill to that appointment. For each one, ask, is this still necessary? Is there a safer alternative?